Good afternoon. I'm Colleen Huebner, Associate Professor of Health Services and Director of the Maternal and Child Health Training Program for the School of Public Health. Today, it's my pleasure to introduce you to Michael Fraser, CEO of the Association of Maternal and Child Health Programs, or as we fondly know it, AMCHP. AMCHP is a national resource, a partner and advocate for the public health community, for others as well, working to improve the lives and health of all women, children, and families in the U.S. The membership includes professionals, advocates, academics. It could include you, certainly family members as well. There's a role for each of us in protecting the health and well-being of vulnerable groups: infants, disabled veterans, disabled children, Native peoples, or new immigrants, just to name a few. This afternoon, Dr. Fraser will talk about how to lend our voices to those who can't speak as powerfully for themselves, why it's necessary to do this to assure a healthy and vital future, and when and where to act to be most effective. And with that, welcome, Michael.
Great, thank you. Good afternoon. I've been really looking forward to this trip for a number of different reasons, both personal and professional, but we've been planning this one for a while, so it's nice that it finally arrived. I'm going to be really nice on you and let you stay up there, but honest to God, really? You couldn't just come down a little bit? All right. We are going to spend about an hour talking about policy, and I'm going to try and engage you, although you're miles away, in the conversation, and there's a couple different ways to do that. So work with me here. What I'd like you to do is consider this question real briefly. It's a true-false, so you have a 50% chance of being right, okay? Text your answer to policy development is a core function of public health. So one person answered, that's okay, one person answered true. We're going to get a few more here. A core function of public health. So I'm going to wait for the votes to tally. We're getting a pretty good bar here. These are your students. Excellent. Great. So sense of the group so far, policy development is a core function of public health. Okay. So part of what I'm trying to do in my talk this afternoon is build your capacity to carry out that core function of public health, policy development. And especially when I go to universities, policy development means a lot of different things to people, okay? So we're going to talk a little bit about the kind of policy that I'm interested in and the kinds of things that we do in Washington on behalf of states. It's a very specific federal legislative policy related to maternal and child health, and we'll talk a little bit about that, okay? So let me just do one more question, then we'll get into the meat of it. So you got the part that policy development is a core function of public health. Well done, and that's good to see. Honestly, it's not all groups have that confidence. But let's see where we feel we are in terms of our competency in this area, okay, as both student, faculty, partners, staff. How confident are you now, just coming into this conversation, that you have the competency needed to influence public policy related to public health in our country, okay? How competent do you feel yourself to be? And I realize that, you know, this is a group that's done probably various work in this area, so. Well, that's good, because by the end, we're going to see that change, hopefully, unless a lot more people vote. Does everybody that wanted to vote feel like they had the chance to send their text? Okay, so strongly disagree, a few folks in the strongly agree part, but basically, the goal today, then, is to familiarize you more with some of the activities that you can undertake as a public health advocate, all right? And my main takeaway today is that although you may be in an academic environment, you may be plotting out research questions and techniques and doing analysis, policy development and supporting the work of public policy and public health is absolutely essential to your work as a future public health professional, and those of us who are in public health now. And that while the scientific endeavor and the research behind the work that we do is obviously paramount here, the work that we can also do that's complementary to that, not separate, is part of our work as public health professionals. So we're going to have some fun. I hope you're relaxed. This is not a serious lecture. I gave that up many, many years ago. And I just want to share with you some of the stuff I think is interesting, important, and relevant to the topic at hand. So we did those questions. And here's another slide that I hope you all have received in your training. But when we look at what public health is all about, and some of us in the room were actually part of the creation of this. I'm looking at Dr. Allen. But, you know, it was important many years ago, probably about 10 or 15, even longer, that it be real clear what it is that public health is all about. And so the 10 essential services of public health were developed. Is this new to anybody? This is a good diagram of the whole enterprise of public health, and you can see how policy development is a core function. In fact, there's a lot of different ways that we do that. You might not be able to see it very well because the resolution on this graphic is a little fuzzy, but the point here being that just like epidemiology, surveillance, health promotion activities are essential to the work that, of a public health department or the public health enterprise, so too is policy development. And the work that we do at AMCHP is policy development specific to moms, kids, fathers, and families. Okay? And even more specifically to that, we are charged through our board and our membership to advocate primarily for the federal program that funds state maternal and child health programs that I refer to as Title V. It's the MCH Services Block Grant. And it's a federal investment that's shared by the states, that's programmed based on state needs to meet the needs of that state's vulnerable populations, especially moms and kids. Okay, so I hope you're fluent in that. If those of you who are taking an MCH policy course, that should be a refresher, but that's really what I'm talking about when I'm talking about federal legislation. But when we look at sort of the lay of the land when it comes to public health more generally, but also to maternal and child health, there's a great aphorism for this. It was the best of times, and it was the worst of times. Any English majors in the room? You know who this gentleman is? Yes, who? They don't want to, it's not Hogness, whoever that was. It's Charles Dickens, right? So the best of times, worst of times, beginning of Tale of Two Cities. I thought it was apropos, Tale of Two States, Washington, D.C. is not a state, but whatever. Another way of saying the same thing is, when it comes to public health policy and the challenge that we have in front of us, you really can see the glass is half full or half empty, okay? And some of us see it both ways, depending on exactly what we're doing. But I think it's important to know we are living in what is probably one of the most exciting times in public health, at least governmental public health, but also one of the most challenging times when it comes to public health. And for those of you who have worked in governmental public health, either through your internships or other projects, you will know, you will have felt just how challenging these times are. And for those of you who are considering that, I hope that this invigorates you a little bit, but also go in with your eyes wide open because there are a lot of challenges right now in the States. And here's just some numbers to set the stage, okay? So the first number, I think it has enough zeros, right? It's 1.5 billion. Did I get that one right? Okay. Does that ring a bell to anybody here in terms of maternal and child health, or might be too esoteric? So that is the amount, 1.5 billion new dollars that have been appropriated through the Affordable Care Act for maternal, infant, and early childhood home visiting programs in the States. Okay, so have you heard about home visitation? Yes, okay. Evidence-based home visitation? Okay. Excellent, excellent. You're on your way. So that's the dollars to support that work in this. Those are the dollars to support that work in the States. Those dollars are new dollars through the Affordable Care Act that we lobbied for with other partners to be part of the Affordable Care Act. Okay. $1.5 billion. It's significant new investment in maternal and child health. Probably the biggest we're ever going to see in any time soon, probably in my lifetime. I don't know about y'all's. Okay. 13 billion. Another maybe esoteric number. That's the total appropriation over 10 years for the Public Health and Prevention Fund in the Affordable Care Act, which funds programs in the community level, but also in the states and academic settings to basically put prevention to work, to implement prevention, health promotion strategies, childhood obesity prevention, other chronic disease prevention in the states. $13 billion in the Public Health and Prevention Fund, okay? Mostly to CDC for Public Health Service Act fund programs, okay? That's incredible. That's incredible. These are big, big numbers. But simultaneously, so that's the best of times. Simultaneously, for almost 10 years, we've seen pretty drastic reductions just in our program, the Maternal and Child Health Block Grant, over 10 years totaling $641 million. I need to add some zeros here, as someone pointed out to me this morning in Olympia. Well done. So we're seeing a constriction in the core Title V block grant, but we're seeing these new resources for categorical programs, okay? 17,800. Any guesses on what that is? The number of public health jobs lost in state health departments since 2008 across the country, okay? It was the best of times, it was the worst of times. Now, no one's going to go work in state public health, and that was not my intent, just to let you know. But what's going on again is this incredible new resource and excitement while there's contraction in the core systems that provide those services in the states, okay? And the federal funding for those. So you can see here some work that was done by one of our other national associations, the State Territorial Health Officials Association, is basically saying, you know, times are not good in the states for the state health workforce. And you may be hearing some of that in the background of what you're doing. Almost 91%, almost all state health departments have eliminated service as a result of budget reductions, okay? And that doesn't mean the needs were met, so they don't have to do them anymore, okay, as you've probably deduced. So, best of times, worst of times. What's really going on? This incredible contraction of resource, okay? And federal budget cuts that are currently in play are only compounding what states have been dealing with since 2008, if not before, with the recession and all those kinds of things. You probably see that here at a state institution as well, okay? So it's not just happening to public health, but you feel that crunch in all states now. And that's having an impact on policy, because policy is really, it's not a complicated definition, it's about rules, decisions, and budgets that impact big groups of people, really. I mean, that's a simple way of saying it, but where we choose to invest our dollars is a policy decision, okay? And is shaped by a lot of different influences. So what I want to do is give you a little bit of a sense of some of those influences today. Here's the glide path of the Maternal and Child Health Services Block Grant since 2003. I started at AMCHP in 2007. That's why we've leveled off. No, I'm just kidding. But, you know, unless you're a skier, this is not the glide path that you want to see when you're looking at services to states to improve the health of moms and kids, fathers and families, okay? And so we've had an incredible fight in maternal and child health. Particularly, there are some glaring exceptions to that, like home visitation. But to get a little more complicated now, I know it's getting late, but to get a little more complicated now, that same glide path in purple is core state block grant funding, okay? And then the yellow piece is abstinence-only teen pregnancy prevention. I'm not even going to talk about that. That'll get me all riled up, and we'll be here for a long, long time. But that core funding has been stable for a lot of different reasons. But the increase, as I mentioned, that blue bar there is the new home visitation dollars. Okay, and the little bit on top is PrEP, which is personal responsibility, teen pregnancy prevention by another name that is not abstinence-only programmed. So you can see new resource here, okay? And at the teeny top is a small grant that's Title V funded for connecting families to services through family information. The point I want to make here is that Congress is colorblind when it comes to looking at this chart, okay? So when we go to advocate for maternal and child health, they're looking me in the face like, what the hell are you doing in here? We have given you $1.2 billion in Title V. How could you possibly ask for more? Okay? And what we haven't done is to be able to clearly articulate the difference in those programs and basically say, well, you really can't do your birth defect screening with your home visitation money, or your breastfeeding promotion with your home visitation money, or now it's your lead screening program with your home visitation dollars. So the new resource is very categorical, very specific, while we're seeing declines in our overall block grant. It's a policy problem that we have. It's something that we are working on. We can talk some more about. Okay? Compounding this problem, and I hate to even say this because it's very, well, you'll make up your own mind. This just came out last week in the Washington Post. DC, and this is an example, DC's infant mortality rate is at a historic low. Is a historic low. And let me tell you, it's bad, okay? Why are we not dancing in the streets on that one? It's still pretty high, okay, yeah. So all things told. But things like this completely undermine one of our core messages, which is babies are going to die if you don't increase funding for this program. And yet we're seeing these successes coming out at the same time. Okay? So the message is even more complicated. The policy argument that we have to make is even more complicated by the fact that we're actually doing well in some areas, and therefore it makes the story we have to tell a lot more complicated. Now, folks will say, well, those data were 3 years old, which is the most recent infant mortality data you can get. Okay? And those are the result of big investments that were made earlier on, and probably in 5 to 10 years we're going to see those rates going down as a result of the cuts we're making now. That explanation that I just told you is way too long to share with someone with this much attention making a decision on a budget. Okay? So we are dancing in the streets. This is, although it's still high, there is definitely opportunities to celebrate, but at the same time it's complicating the policy message even more, which is when you cut, there's going to be hurt. And we haven't been able to clearly articulate that hurt right now because of the way our data are collected and the stories that we need to tell aren't collected. So just complicating the policy environment even more. And we have this incredible opportunity in health reform now to actually address some of the core maternal and child health needs across the country. Amazing opportunity to support public health and prevention, to expand access, to invest in the public health workforce, to really think through what a core comprehensive benefits package would be for private market and then Medicaid in the states. It's an incredible opportunity. And all of that, too, is, as you well know, and I'll talk about a little bit more, in a very delicate balance right now. So I don't know what the current rate of Ativan use in DC is now, but pretty much everybody's got some major anxiety disorder, just waiting for this Supreme Court decision. We'll talk a little bit more about that in a sec. So all of this sort of brings me to why is maternal and child health such a tough sell? Okay? So, here we have, this is last week, USA Today, that dropped off in front of my hotel room. On the front page, 2 really big MCH issues in the spotlight. 2 really big Title V maternal and child health issues in the spotlight. Autism, which is an emerging area that we're all very concerned about and trying to do a lot more work in, and teen pregnancy on the front page of the USA Today. So you'd think that advocacy for maternal and child health populations would be really easy. So I just want to ask you off the top of your head, and we'll do this poll everywhere right now, how easy do you think it is to advocate for MCH issues? Because, after all, everybody loves kids and motherhood is American as apple pie. You'd think it would be an easy work. It would be easy work to advocate for maternal and child health. And frankly, it is in terms of getting the messages out. The receipt of those is more often than not falling on deaf ears, which to me was a big eye-opener. So you got here about 80% of you thinking that this is really hard. And quite frankly, I was shocked at how hard it is to advocate for maternal and child health, and more specifically for the maternal and child health block grant. And here's one reason why. Okay, so this is a congressman from Michigan's 1st District, and he was very proud of displaying this sign in his office that if you were here to ask for more money, you're in the wrong office. Okay, there's incredible, ideological divide that you all are probably well aware of now in DC, where there's a tremendous push for shrinking the size of government. That's the line they use, okay? And the incredible push to control the deficit and control the federal spending, et cetera, et cetera. And that's true. I mean, I think if you look at the numbers, that's true. But honestly, if we honestly look at our federal budgeting process, it's a statement of our priorities. Where are we really putting priorities? Where are we really doing our spending? Okay? And I would posit to you just individually as Mike Fraser, not as CEO of AMCHP, because we don't have an official position on this, but I would posit to you that it's not a money problem that we have in this country. It's a priorities problem that we have in this country, in the richest country in the world. I mean, let's just say that, okay? That's my frame. A lot of other people disagree with that, and that's part of what makes this such a difficult endeavor for something that you would think would be relatively straightforward. The states are hurting. How this is all playing out in the states is also very difficult. So we have this new home visiting investment. States are saying, well, we don't want it. So here you have states cutting their budgets, reducing services, elevated need because of the recession, turning away federal dollars because it's either related to the Affordable Care Act or they don't think it's important enough to receive those to manage them, okay? This case is just an example of a case in Florida where they didn't want any of the new home visiting money. They changed their mind fairly soon after this headline came out, okay? Because they were shamed, basically, into taking that. But you have half the states suing the federal government over the Affordable Care Act right now, okay? And that's the policy context in which people are trying to do public health work. The need for MCH advocates, for maternal and child health advocates, and by extension public health advocates, is not a new need, okay? The activism of the early 1900s in maternal and child health was firmly rooted in what I would say were public health professionals. They may not call themselves that at the time, but in their realization that to improve health, we had to address issues of equity, inequity, and make the link between improving living conditions, working conditions, education conditions, and health. Okay, so here's an early chart that I love this, epidemiology from 1923, which is correlating father's income with infant mortality, which, obviously higher father's income, lower infant mortality. Okay, and that being used to craft public health programs to address infant mortality. The Maternal Child Health Block Grant has been around 76 years. It was the first federal public health program that really initiated the creation of state health departments. And those early programs were about child labor. They were about cleaning up housing. They were not about necessarily doing the kinds of work that we do today, but that thrust is still there. I love this sort of early march, and kind of tying in the MCH activism of the past to where we kind of need to get back to. It's like back to the future here in terms of where we need to be as public health advocates. That's why I'm so excited to be talking to you, because I think you're that next group, okay? So is it clear now how this policy development piece fits into the work that you do as public health professionals? That's kind of tying that back up, okay? So what do we do with all of this? So you're sitting here thinking, well, I got papers to write. I got, whatever it is. Do people take tests anymore? I'm not familiar with that. But, I got stuff to do. I got research. I got grants. That's Mike's job. He's got it covered in Washington. I don't have to worry about that. Well, that ain't the case at all. And I want to talk to you a little bit about that, okay? Because we all have a privilege and a right to be lobbyists, guaranteed in the First Amendment of the Constitution. We have the right to petition the government for a redress of grievances, especially you, okay? Because the folks I work with in the states are very constrained in their ability to lobby. They work for the executive branch of the state government, and the governor wants to control the message. He doesn't want his MCH director out there asking for more money if he or she doesn't want that for their state. But you all have a lot more degrees of freedom in this conversation, which is, again, part of the reason why I wanted to share with you. So the opportunities to educate, inform, and then ultimately lobby, if that's something you can do, really are tremendous. But part of it is getting to figure out how can I do that, and how can I do that effectively as an advocate. All right? Now more than ever, we need folks advocating. I mean, the whole perception of the system is that it's completely broken, and we can have a whole conversation about that in the future. But you can see here that congressional approval ratings, over the past year or two, are just in the tank. I mean, 10% of people approved of the way Congress is handling its job in March of this year. I'd like to know who they are. They probably all work for members of Congress or something like that. So the majority opinion is something's not working, we don't understand the system, and I think that's true, but it is the system we have at some level. And it's important that we understand how to work within that if we really do want to see change, realistic change. okay? So let me ask you this. Do you agree or disagree, or is this true or false for you? If you knew that how laws were made, you'd be more likely to participate in the policy-making process. Let me ask you that in a poll. So not so sure. So the predominant group saying here, not so sure. Why is that, do you think? Has anybody seen the movie Mr. Smith Goes to Washington? Okay, so do you want to do like a 10, 15-second recap on that for me? Anybody? It's what's it all about? A novice senator gets elected, goes to Washington to change the world, right? And
it's an idealist, and then he confronts people who live by cynicism, graft, and kind of hidden deal.
yes, so is an idealist who's confronted when he goes to Washington with cynicism and graft and corruption and all this stuff that we have to deal with. Yes, indeed. So here's how he sort of approaches the lawmaking process, the policymaking process as a novice, okay? And I think it's a little bit instructive. So he wants to introduce a bill to fund a boys' camp. Okay, so that's the bottom line. So we're going to watch this for a couple minutes and then talk about the process. Ready?
Right ahead with it.
We're going right ahead with what?
The bill, my bill for a national boys' camp. Where's my briefcase? Oh, there
Just
it
a
is.
moment. Do I understand that you're going to present a bill?
Yes, Senator Payne and I decided it was the only way we could...
Senator Payne
What?
decided this with you?
Yes, it was his idea. Of course, I should have been the one to think of it.
My dear Senator, have you the faintest idea of what it takes to get a bill passed?
No, you're going to help me.
If I were triplets, I could.
Well, now, Miss Saunders, Senator Payne said that you're going to help me. Now, what do we have to have? What books do we have to have?
Look,
And when
Senator,
how do we write
do
the
you
bill?
mind if I give you a rough idea of what you're up against?
No, go ahead.
Well, our senator has a bill in mind, like you, a camp, right?
Right.
Fine. Now, what does he do? He has to sit down first and write it up. The why, when, where, how, and everything else. Now, that takes time.
Well, but this one is so simple.
Oh, I see. This one's simple.
Yeah, and with your help, why, we
Oh,
could
I'm helping, yeah. Simple, and I'm helping, so we knock it off in record-breaking time of, let's say, 3-4 days.
Oh, a day.
A day?
Yes, just tonight.
Tonight. I don't want to seem to be complaining, Senator, but in all civilized countries, there's an institution called dinner.
Oh, sort of hungry myself. Well, couldn't we sort of have some stuff brought in on trays, like big executives?
Oh, sure. Mm-hmm. Well, dinner comes in on trays. We're big executives. We're light into this.
And we finish the bill before morning.
Yeah. It's dawn. Your bill is ready. You take it over there and introduce it.
How?
You get to your feet in the Senate, take a long breath, and start spouting. But not too loud, because a couple of the senators might want to sleep. Then a curly-headed page boy takes it up to the desk, where a long-faced clerk reads it, refers it to the right committee.
Committee, huh?
Committee.
Why?
Look, committees, small groups of senators have to sift a bill down, look into it, study it, and report to the whole Senate. You can't take a bill nobody ever heard about and discuss it among 96 men. Where would you get?
Yeah, I see that.
Good. Now, where are we?
Some committee's got it.
Yeah. Now, days are going by, Senator. Days, weeks. Finally, they think it's quite a bill. It goes over to the House of Representatives for debate and a vote. But it has to wait its turn on the calendar.
Calendar, huh?
Yeah. That's the order of business. Your bill has to stand way back there in line unless the steering committee thinks it's important.
What's that?
What?
The steering committee.
Do you really think we're getting anywhere?
Oh, yes, Miss Saunders. Now, tell me, what's the steering committee?
Committee of the majority party leaders. They decide when a bill is important enough to be moved up toward the head of the list.
Well, this is.
Pardon me, this is. Where are we now?
We're over in the House.
Oh, yeah, House. More amendments, more changes, and the bill goes back to the Senate. The Senate doesn't like what the House did to the bill, they make more changes. The House doesn't like those changes, stymie.
So?
So they appoint men from each house to go into a huddle called a conference, and they battle it out. Finally, if your bill is still alive after all this vivisection, it comes to a vote. Yes, sir. The big day finally arrives, and Congress adjourns.
Okay, so it's a little cynical. Let's be realistic here. But the process of legislation obviously is complicated. But I love the way this just sort of lays it all out. But let me go back here, and there's another way of saying the same thing if I can get to it. Yeah. So we're just going to talk about this for a little while. No. So, I mean, what I want to share with you is, obviously, I'm talking about influencing policy making happens at all of these steps. It's a complicated process, one that's very involved, all right? And there are rules to influence what the priorities are going to be and what's not. What's good to know about Maternal and Child Health Block Grant in particular is we don't go through that process every year. The Maternal and Child Health Block Grant is part of the Social Security Act, which is permanently authorized, which means that all that happens on an annual basis for maternal and child health is appropriations, putting dollars to legislation that's already been enacted. Because 76 years ago, they decided, let's not have this debate every year, every 3 years, or every 5 years to reauthorize Social Security. So what I want to get to you is, it may be something you're interested in to go back and look at your Civics 101 if you had it, and if you didn't, to think a little bit more about that process so you can see where you as advocates can insert yourselves. But when I'm really talking about MCH advocacy from AMCHP's perspective, we are really talking about influencing the appropriations process for maternal and child health, because we don't have the need for a lot of new legislation. We have the need for resources to appropriate to the legislation that we already have in process. So that's just a little caveat there, but also important for you to know. Okay? So this gets back to your comment earlier about the factors involved in policymaking. And I want to poll you, again, get some feedback here, on what you see as the most important factor, or what factor has the most influence, let me say it that way. Which factor has the most impact on policymaking? Is it the experience and expertise of the legislator or their staff? Is it that legislator's judgment? Is it the resources that they have available to them? Is it their habits and tradition? Is it lobbyists and pressure groups that are pushing them to make certain decisions? Okay. Is it pragmatics and contingencies? Is it evidence? Is it the facts? Or is it the values that legislator either has or shares? Interesting. Can you all see this from back there? It's a good sense of the group here. Okay, so here we are, about 23 of you have answered. Here we are in an academic setting. True? Okay. And hopefully the results of the research you're doing and the work that you're doing is leading to an evidence base to inform something other than your CV, okay, that is going to lead to change, and it does. I'm not being facetious or disparaging. But you're also savvy enough to know that something else is going to influence the decisions that are made related to maternal and child health policy and public health policy more generally. How do you feel about that? None of you put evidence down there. Huh? How do you feel about that? Being realistic, huh? I don't want to discount the value of evidence, honestly, but there is a real need to realize that even the best and most sophisticated data and analysis that you present is not necessarily what's going to drive policymaking, okay? And that's a really interesting conversation that we could have, but what that means to me then is, as an advocate, where we can have the most impact and the strategies that we're going to use are not going to necessarily be as reliant on sharing a bunch of data and hoping for change, right? Yes? Lobbying and pressure groups. Just to be real about it, frankly. Their values are also pretty influential these days. I will give you that. But in terms of the most impact, lobbying and pressure groups. Now, how many of you saw Thank You for Smoking, the movie? Okay, I should show a clip from that in a future presentation. There's good lobbyists and bad lobbyists. Okay, as I mentioned, you all too are part of that advocacy endeavor. Okay, so I'm not talking necessarily about all the bad guy lobbyists. I'm talking, we have lobbyists for maternal and child health. We need your help in that endeavor. So, interesting. Thank you for responding to that. Let's keep going here. In terms of the So here's, I got the chance to testify before Congress a couple weeks ago. Absolutely incredible opportunity. You can see how full the committee members were. But no, they were all coming and going. So this was like a staged picture. But the opportunity then for someone like me to have, to really take the work that you've done and translate that into a very specific ask, which is what lobbying is really what we have to talk about. Because I need the stories and the data to do my job, and you're the ones that are producing that for us. So I don't want to disparage and leave you with the fact that evidence is meaningless. That's not true at all. It influences the work that we do. But how we share that and the ways that we do that are very strategic. So imagine having 5 minutes before a congressional committee to make the case for level funding for the Maternal and Child Health Block Grant. What would your talking points be? You can't bring in the state needs assessment and say, let's do this. You have to be very, very crisp in what you're doing. So that's one strategy, the direct lobbying that we do on the Hill. But we also do a lot of communication with our partners in the states to get the message out that stuff's going on in DC, and we need help asking for level funding for the Maternal and Child Health Block Grant, educating, informing about what cuts to the block grant might do, cuts to other public health programs might do. So this is just an example of one of our legislative alerts asking folks to participate in this process, this sort of grass tops process of contacting their representatives and amplifying messages that we're sharing in Washington. And what's really, to me, the best compliment then is, so here's our alert that we send out. Partner groups then take those messages and send them out to theirs. So you probably can't read this, but this is a piece that we did that was repurposed by the National Family Planning and Reproductive Health Association, pushed out to their members. So it's sort of this snowball impact that we can have. So while we have 17,000 people in our database, my guess is our reach is much deeper than that because people forward it, they incorporate it into their messages. And that's something that you can do if you're getting our messages or you want to get our messages. Take them and then share them with coalitions you work with, folks you work with. And really, it doesn't take that much effort. So those of you who are asking about the time commitment to this can be 5 or 10 minutes, especially in the links that we provide. But those 5 or 10 minutes, when we go visit Congress and they've heard from even 5 or 10 constituents, they're going to pay attention to the issue. We're not talking about millions and millions of people needing to call. They want to hear from 5 or 10 people. I mean, more is better, but even that much for the work that we're doing is high impact. Because what's more the case is we get the message, we haven't heard anything about this issue. And so how important can it really be? And you're paid to do this work, but if the folks that are actually at home voting aren't doing this work, we're not going to pay attention to it. So very crucial part of the work that we do is amplifying through our partners and folks that we contact with at a very grass tops level. So part of what I want to do is show you that impact. Okay, so I hope nobody tries to friend me or something in the middle of this. But this is my Facebook. And how we get it to large screen, I'm not going to worry about right now. But this is Congresswoman Roybal Allard from California. And this is a floor speech that she gave last year, in February of 2011, when there was a proposed $210 million cut to the Maternal and Child Health Block Grant. Okay. And what we did then was mobilize our groups to share the message that that cut would be detrimental, and then provide her office and her staffers with the reasons why. Okay? And so I wanted to share this because this is a very good example, and we can talk about it at the end, of how you too can influence a policymaker's action. Okay? So you ready?
Opposition to this continuing resolution because it ignores the needs of America's families and does nothing to create jobs, strengthen the middle class, or effectively lower the deficit. The $1.3 billion cut to community health centers is astounding. In my district alone, if these cuts are enacted, over 112,000 individuals will suffer a significant loss in primary health services, and they will be forced to use costly hospital emergency care. Nationally, these cuts mean health centers will be unable to serve 11 million patients over the next year. It means 127 new health centers in underserved districts will lose their funds. And it means the loss of thousands of healthcare jobs. Also on the chopping block is the Title X program, which provides over 8,000 men and women in my district with reproductive health care and cancer screenings. Nationally, the $317 million cut to Title X will force many clinics to close, eliminating another primary care safety net for 5 million men and women. Also unbelievable is the $210 million in proposed cuts to the Maternal and Child Health Block Grant Program. This cut will devastate primary and preventive health services in California for an estimated 2.6 million pregnant women, infants, and special needs children. The cuts also endanger other critical programs, such as California's newborn screening program, which last year tested almost 550,000 newborns for treatable genetic and metabolic diseases, which, if undetected, could have become painful and life-threatening. On the national level, these cuts in MCH grants will reduce or eliminate prenatal health services for 2 million women and primary health care for more than 17 million children. In a country that ranks far behind almost all other developed nations in maternal and infant outcomes, we can ill afford to slash funding for the only federal program that focuses solely on improving the health of mothers and their babies.
Makes you kind of want to move to California, doesn't it? But let's talk about that for a sec. I mean, talk to me about your response to that. What did she have to say? Okay, and part of what I think she was trying to do was show impact of cuts, but absolutely, you know, that might be too much. Okay, but how do you think she got those data? There were a lot of data from us, yeah, from you, he says. Yeah, I mean, yeah, it's not like the staffers are sitting around saying, let's get some good data that we can give for her floor speech. I mean, part of what we do, and you ranked lobbyists and pressure groups as the most impactful policy factor there. You know, that's what we do, is provide those data, okay? So if we didn't engage with their staffer about the block grant and kind of have that conversation, she never probably would have even included it on here. So while you're right, getting more savvy in our message and probably being a little more appealing to bigger values and kind of a core message is going to really make a big difference, and that's something that we really need to talk about for the public health enterprise overall. That very simple act of contacting your member or your representative with some pretty key information about what impact is does actually get translated into things like this, which eventually become part of the record and actually may influence policymaking. So it's both a pro and a con, I think is what I'd like to take away from that. But there's other ways you can do that. I mean, here we have an op-ed, which is another strategy that we rely on, that talks about the value of the block grant that we try and place in newspapers. And this time of year, Mother's Day, we use very strategically to send across the country to all our press contacts op-eds about why the block grant is an essential investment. Now, it didn't make the Wall Street Journal, it didn't make the front page of USA Today, but it did make the Des Moines Register and the Lexington Herald Tribune, Lexington, Kentucky. Why should we care? Why is that a big deal? Whoever reads those. Any ideas? Well, some, Kentucky, but the Senator Harkin, chair of the committee that appropriates for the health funding in the Senate, and who's the Senate leader, minority leader now? Where's he from? Mitch McConnell from Kentucky, okay? So they read those papers first, and then if they have time, they get to the Washington Post, okay? So you may come from a place with the senator or representative on a key committee, and I can tell you that, or you can look it up online, And there's really only 20 or 30 of those folks that you really could get to and say, as a constituent, as a public health student, as someone who is interested in this and following what you're doing in Washington, I urge you to make this choice. This is my ask. That goes a really long way. So it's not like you have to get to all 500 members of Congress, 435 members of Congress. It's a much smaller set than that. And that hopefully gives you a little relief to what could seem like a very big task. Makes my job a little bit easier too. Okay? So that's another strategy that you could use. Or you can go visit. Okay? So we have members that come in for our annual conference, and while they're there, take time to go up on the Hill and visit with their elected leadership if they're allowed to, talk about what they do with the block grant, to educate and inform them about the work of that federal program in their state. Okay? So there's a lot you can do. We don't have to create a lot of new legislation. We don't have to create a lot of necessarily new technique here, but we have to be very strategic with what we have, and we can influence the policy development process. So these are one of my president-elect and another member that we're going to visit there, Congressperson Max Baucus from Montana, whose committee has oversight over the Maternal and Child Health Block Grant, the Senate Finance Committee. Okay? So it actually can be quite fun, and it's something that I recommend you all do. Okay? So here's where we're at, and we'll sort of conclude with a little bit of conversation and maybe talk some more. Here's where we're at with regards to some of the policy work that we're doing right now. We're at a point in American politics, as I mentioned when I started, which is historic, okay? And we have, this is being video recorded, so I'm trying to be very conscientious. We have ceded what would normally be a political process to really two people, maybe even one, okay? One Supreme Court justice will decide the fate of the Affordable Care Act, okay? It's interesting. Isn't that why we had the American Revolution to begin with? I mean, the whole notion that a lot of what we care about and a lot of what's exciting right now in public health is tied into the decision around the health reform and the Affordable Care Act. To me, it's pretty intense when you think about it. So there's a tremendous amount of uncertainty right now in Washington when it comes to public health policy, because our biggest and most exciting pieces of that are tied into the Affordable Care Act for many reasons. And the fate of that bill rests not in the fact that the Supreme Court thinks home visiting is a bad idea, or teen pregnancy prevention is a bad idea, or a public health prevention fund is a bad idea, but in the notion that is it constitutional for the federal government to tell the states that they have to provide insurance to every one of their citizens, okay? And so all of what we're talking about is wrapped up in that interesting, but in some ways unrelated constitutional question, okay? How this is going to resolve, oh man, I wish I knew. If I knew, I wouldn't be here. I'd be around the world with a crystal ball that worked, okay? So I think that's really important for us to realize, that that process was so gunked up that it led to, to this bumping it up to the Supreme Court. The only thing that we do know is that for the foreseeable future, we will be seeing cuts. Regardless of what happens with this, because the super committee failed to come up with an agreement to cut the $1.2 trillion from the federal budget for 13, on January 1st of 2013, there will be an across-the-board cut of 7 to 9% of all federal discretionary programs. And so, again, there's an opportunity for advocacy, but that's a pretty certain thing. That's a pretty certain thing moving forward. So what I was hoping to do was share with you some of the work that we do, share with you some of the very simple tactics that we use, share with you the urgency for this work, and hopefully enlist you in being part of that work that we all need and that we all do. Okay? So let me do a quick closing poll here, if you don't mind. Let's see if we had any change. I knew if we had more time, I could really get this up, but let's see what we got here. In terms of the post test here, same question we asked before. How confident do you feel that you have the competency needed to influence public policy related to public health in the United States, based on our thinking of our hour together? Still a fair chunk. Well, I think you can see from the numbers that we do have some more work to do, but hopefully you want to be part of this process, and I'm happy to share our newsletter with you, or get you on our legislative alert list. If you want to give me your email address, we'll add you to our database just so you know what's going on. And hopefully this is a good adjunct to some of the work that you're doing, that's more academically focused, more research focused, in terms of using another part of your core competency as public health professionals. So with that, I'm going to thank you for the opportunity to visit with you this afternoon, let you have a chance to ask questions if you want, or we're just visiting afterwards. I'm not sure what the plan is, but we'll turn it over. Sure.